can't. Let's have a look. Yeah, got a few people on. Hello, everybody. We're due to start our dermatology meeting. I know that people are just joining and coming across from the other meeting. So welcome to everybody. Just give people a minute or two to come across. I think in the meantime, I'd like to introduce Claire Martin-Simmons. So Claire's a dermatologist at UCH, and she's the NCL lead for dermatology at UCH, and she's going to be leading this webinar. But we've also got Andy Murphy on the call, and Ollie Gregory, and Amelia. Yeah, she wants to sort of wave, Amelia Robson, who all work with me in the Cancer Alliance. Okay. And as most of you know, but I'll just repeat it, I'm a GP by background, but I'm co-clinical director with Daryl and Hughes of the North Central London Cancer Alliance. And I can see also some of our GP leads. We've got a lead for each borough now in NCL for cancer that the Alliance is funding. And welcome Nitika, who's joined, and perhaps others will join. Great. Okay. So Claire has to go. She has a meeting that she needs, an MDT that she has to go to at 12:45. So we will finish at that point. And if there are leftover questions, if you please put them in the chat and we'll pick them up later. Claire's going to give us an overview of dermatology and the pathways as they are in NCL, making reference to advice and guidance, which we and the different ways you can access that type of guidance for GPs and for anyone, and perhaps your practice nurses or assistants, physician's assistants who are working, seeing patients with dermatology conditions. And I think what Claire will focus on today is use the time to look at referral volumes, the stretches in capacity, the seasonal character of skin services and the stretch that skin services have to adapt to. We'll hear some examples of potentially avoidable referrals that are seen by dermatology, particularly those that come through the USC and that could have been routine, just to try and impact on the referral outcomes a little bit. And we'll also understand a little bit about the current situation with our teledermatology service, what we can do as GPs to optimise the referrals as they're going through that. Claire, I know, will also talk about some future plans and innovation within the USC skin space, and that'll probably take us up to time. Claire's left lots of time for questions, I know, and so that's will be a conversation. So, Claire, I think, will you be happy if people want to raise their hand mid-talk? That they can do that, and then we'll have a sweep up of extra questions at the end. Thank you very much, Claire.
Great, thanks, Claire. Yes, so obviously I sort of mentioned what I'm going to be covering. Dermatology can be quite complex, I think, when there's so many different referral pathways and when the demand is so high. So if I just have the second slide, Andy, thank you. It will repeat pretty much what's going on, but yeah, as I said, we'll chat through our different pathways, so the different dermatology pathways, that's the option, certainly challenges within the system from both ends, so primary care and secondary care. There are certain avoidable skin cancer referrals, and we'll just chat about those. Telederm, specifically around a kind of new service, the urgent suspected skin cancer telederm, I'll chat about, and then future plans, innovation, and then obviously open up to any questions. So anything that anyone wants to ask, please feel free. So next slide, please. So if we look at the current pathways, I mean, already you can see there are actually quite a few. So I've sort of clumped them into routine, urgent, and then the sort of cancer. So if we just look at routine, so the kind of classical via ERS, the non-urgent, non-suspected cancer referrals, and these are the ones that really patients are requiring a face-to-face appointment. So they are the bulk of sort of the routine referrals. We also have routine telederm, So this is, again, non-urgent, sort of non-suspected cancer referrals for those that are appropriate for telederm. So sometimes that might be that you think you're on track, but you just need a bit more advice on maybe further management, or there's a rash that you think you know the diagnosis, but not quite sure, or indeed if there's a rash and you don't know what it is. But it's amenable, it shows well on photographs, the patients are happy, and you have enough information that you can refer. The other thing that gets referred for routine is a benign skin lesion where you think it's benign, you're pretty sure it's benign, but you're just not 100% sure and you want it double checked. So that's also used. I mentioned the GP with a extended role. So within our sort of patch, that's really Haringey, and they have a really good service, but it is limited to that area, and we don't have it across the whole patch, but that's certainly used for routine dermatology. And then also there's advice and guidance, and within UCL generally this is consultant connect, so this is not something that secondary care does. It is commissioned in primary care by primary care, so we don't in secondary care we don't have anything to do with that side, but it is absolutely available in primary care, and it gets used quite a bit because it's a very quick turnaround, so you get almost an instant advice back. So those are the kind of routine. Then if we think about the urgent non-cancer, so these are patients that their skin is really in a bit of a state, you need to see them quite urgently, and I kind of see that there's two sort of groups of patients. There's one where they really can't wait routine. They need to be seen relatively quickly. So that would go through the ERS as an urgent. But then there's the patients where they are really struggling. They've got really quite severe skin disease. You need to get an answer really quickly, and that is where the on-call referral system is useful. And we see a lot of patients via this, and they're patients where that they come in to see you, and you really don't know quite what to do or where to turn next. And so that is absolutely available, and that is each trust has an on-call referral, so it's UCLH, the Whittington, and the Royal Free. North Middlesex obviously is now part of the Royal Free. They don't have an on-call, but it's all within the Royal Free now. And then we have the urgent suspected cancers. So these are patients where you are suspecting they have a skin cancer, and that's obviously through the urgent suspected skin cancer. I've just listed adults and pediatrics, and the reason for that, so for adults it's quite clear, they go through the skin pathway, and there's a form for the urgent suspected cancer. With the pediatrics there has been a little bit of uncertainty, so all patients, whilst you still use the same urgent suspected form, it goes into the pediatric referral path. So there's a referral pathway for suspected cancers in the pediatric population. When the trust receives that, they then forward it on to the dermatologist, and it's seen in the appropriate clinic. And then the other thing I'm mentioning is the urgent suspected cancer telederm. I'm going to come a bit more to this, but this is something that is a relatively novel way of seeing patients. But it's sort of across nationwide. This is being implemented as a way to try and free up capacity and reduce the need for face-to-face appointments. But I'm going to be coming back to that and speaking a little bit more about that. Next slide, please, Abby. So there are quite a lot of challenges in the system, and the main challenge is just the sheer volume of referrals. And we just get, year on year, there's an increase. Unfortunately, without really the increase in workforce, as I'm sure you are also all experiencing in primary care. This is certainly in no way limited to secondary care, but I'm just letting you know sort of in secondary care what we also have challenges with. And not only do we have an overall increase in referrals, there's a lot of month-to-month variation. So this is just an example. In the 24-25 year, in June, if we compare June and January, there were over 2,000 more patients referred in June compared to January. Now, whilst okay, we can think about why that might be, etc. It puts a massive strain on the department because you have to try and flex around this increase in referrals, and it can be a real challenge. So yeah, as well as the demand, also the variation is a challenge, and we'll come to that specifically around the urgent suspected cancer. Okay, next slide, please. I think that might have you just gone on. Just go back one, Andy. That's it. And I just put this in here because there's actually really good resources. So we're always thinking, okay, how can we manage the increase in referrals? And I've sort of put a link on there, but there's a lot of pathways. And so before referring, it's always really, really helpful just to check on these pathways. And they've been updated relatively recently, and that was in sort of NCL, so sector-wide revamp of them, and they're in kind of flow charts. And also these are really helpful, I think, if you are, say, having to rely on allied health professionals to also deliver services. They can use these as a resource, and it can greatly reduce referrals, because we do still see quite a lot of patients where it appears that potentially the other things could have been done in primary care that haven't, and they've been referred quite early on in their condition, I suppose, whereas if the pathways are checked and the guidelines are checked, potentially there could be some more options in primary care prior to referral to secondary care. So I just sort of point out that that's a really good resource. Okay, yeah, thanks, Andy. Next slide. And then this is for the cancer referral. So again, the story continues. There is a huge month-to-month variation, and we see it year on that in the summer, referrals for skin cancers, suspected skin cancers, increase. We think it's because everyone goes on their summer holidays, they're on the beach, they're taking their clothes off, and people are noticing lesions. And sometimes, family members will notice something on the back or whatever. But generally, the referrals go up in the summer. So not only is that a real challenge because suddenly we've got a huge tranche of referrals with no capacity, also the actual workforce in the dermatology department go on their summer holidays as well. So the combination can make the summer months really, really challenging. And we are always having to think about how we manage this seasonal variation. So I suppose more so than ever during the summer, it's really important to think, can we in any way make sure that the referrals that are coming through absolutely need to be coming through the urgent suspected skin cancer pathway. We also have a limited consultant workforce, and we have to allocate that to the resources. So, for example, when our urgent suspected pathways, the referral numbers are going up, we then have to move staff away from the routine. Then that has a massive impact. So then you can't get the routine referrals seen. So it's a real challenge. And I think also we see that when the routine referrals, when the weights go up, the referrals to the urgent suspected cancer go up, because it's almost as though the delay is so long to get the patient seen in a routine that then, understandably in primary care, there's the worry, so they need to get this patient seen quickly, so they might potentially use an urgent suspected care pathway, as obviously that is a lot quicker. And also it's a real challenge recruiting dermatologists. There are not a huge amount of us, and there's a lot of unfilled posts around, and this is again nationwide, so it is a real challenge on us meeting the demands. And we are often seeing patients just outside clinic time, added extra just to try and get through the pathways, making sure they're all being seen on time. Thanks, Andy. Next slide. The other thing just to mention, and this is thinking about, how do we make sure that patients that are referred are absolutely will need to be referred into secondary care? And one we see quite a bit of, but also we're getting huge pressures to make sure that we are not treating patients that have these conditions that don't meet these standards. So it's actually, if you look on the left, there's a lot of conditions whereby actually, unless they are, and again, this is on the right side. So unless they are significantly traumatized on a regular basis, and if they're obstructing an orifice, or if it's causing a lot of pain, or it's becoming infected, those are the only sort of criteria which we are then allowed to treat them, or rather we get funding to treat them. And each trust looks at this really carefully, and they basically just won't pay for anything that we're doing that don't meet these criteria. But what is really challenging for the workforce seeing these patients is that obviously these are generally routine referrals, so the patient has waited a long time to come and see us. We see them, we confirm generally what the general practitioner has said the lesion is. So we go, yep, that is correct, it is that. And then it's, well, sorry, that's it. And the patient can get really, understandably, quite unhappy. They've waited all this time to be just told exactly the same thing, and there's no treatment. So I suppose a ask from secondary care is, when you are referring these sort of conditions, just to be really mindful that there's a chance when we see them we can't do anything other than confirm what you have already told them, unless they really clearly meet those criteria. Next slide, please. And then if we're thinking of urgent suspected care referrals that could be avoided, now I'm always very kind of cautious about, saying how do we avoid, because basically these are patients where there is a suspected skin cancer. So absolutely, we do not want to avoid those referrals. So I suppose it's teasing out the patients where there could potentially be another pathway that they are more appropriate for. So we interestingly see quite a few rashes, and again we see this more when the wait for routine is going up. And often it is patients who have a severe rash, so it's totally understandable that from a primary care perspective, they cannot manage this patient in primary care. They need to be seen. They're told that it's a 6-9 month wait. What do they do? And I would just say, if you have any patients like that, always consider the on-call referral, because these patients are seen within a day, 2 days, and it's we use this. We see a lot of patients through this pathway, so it's a really good way of referring patients with a rash that you're worried about. Even if you're worried that, is this rash a cancer, for example, a cutaneous lymphoma, because actually the lymphomas don't go through, cutaneous lymphomas are not through our urgent suspected skin cancers. They're just, I'll come to that, but melanomas, SCC, and high-risk BCCs. And then going on to BCCs, we get a lot of referrals for BCCs as well. And for BCC, it's only if there is a concern that the delay, in other words, if they're put through either an urgent or routine, that delay will have a significant impact. And that really is around, is that lesion near the eye? Is it near the lip? Is it on a site that, if it continues to grow, that is going to then be a problem? So BCCs generally are slow growing, and if it's a BCC in the middle of a large area, a small growth in its size doesn't have a huge impact, whereas obviously if it's right next to the eye or something like that, then clearly they need to be seen urgently. So it's just, again, be mindful. Okay, do I think this is a BCC? Yes. Am I sure it's a BCC? Yes. Is it in an area that I'm really worried has a significant impact? And then we get quite a lot of patients where we chat to the patient and they will report, yep, I've had this all my life, this mole, and the GP wasn't worried, but they said just to be on the safe side. And totally understand that you need that reassurance, and to be able to, for that patient to see somebody to say, yep, it is fine. But just for those patients, consider either a routine face-to-face, potentially a telederm. So if you're thinking it's probably a benign, it's absolutely fine to send it through the routine telederm. Obviously, it must have a dermoscopic picture. And also the Advice and Guidance Consultant Connect, from my understanding, they will also advise on lesions, providing it has to have a dermoscopic picture attached. So there's a few other other routes that you can refer. Next slide, please. So what we are doing now is to try and free up face-to-face. We're putting in this telederm urgent suspected skin cancer pathway. And we're doing this at the Royal Free, UCLH and Whittington. And these patients are triaged post-referral. So primary care have referred them in for a 2-week wait appointment. We have an administrator triaging them against clear criteria, which I'll just mention in a minute. And if those patients are deemed that they meet the criteria, the patient is then called and offered a telederm appointment. And what that means is that they're invited in to have a photograph. That's a macroscopic and a dermoscopic picture. That is then reviewed by a consultant dermatologist, and then the outcome is either reassure and discharge, book for face-to-face if the diagnosis is uncertain, or we can actually book straight to either a biopsy or an excision. And you could argue, well, that's still using consultant dermatologists, and absolutely, we're still using the same workforce, but theoretically, a consultant dermatologist can work through more patients sent through a telederm than a face-to-face. So it just frees up a little bit of time to get through, in a way, more patients. And the criteria are that it's a really clear lesion and in a clear location. It's not in any intimate areas. No risk factors, and these are actually stated in the referral form. So that's things like previous skin cancers, or if they're on immunosuppression, that they have good performance, so they're fully active. There's no access needs, as I mentioned, no history of cancer. We definitely need a phone number because we have to ring those patients up and ask if they mind coming in. Just reading that very last thing. Yes, and also because they are being, the person taking the photograph sometimes is a medical photographer, it can't be in an area where a dressing is need to be removed, basically. So it has to be in an area that's easily photographed. Next slide, please. And then for us to be able to triage these patients, it is so helpful for us to have the form really complete, and any unclear information means that patient cannot be triaged to a telederm and they have to remain on the face-to-face pathway. So theoretically, there are patients that we could change to a different pathway, but we're unable to just because the information is not there and it's not clear. And so the things that are really, really helpful for us is a really clear location of the lesion, because remember, these patients are going to be coming to see either a medical photographer or an HCA, and they have to look at the form and know exactly which lesion they're being referred for and which lesion to be photographed, and also the number of lesions. So if it's more than 2, I hope I'm right in thinking that, I think it's 2. If it's more than 2, then they have to be seen face-to-face. Any risk factors, so we're looking to see, should actually this patient be seen as a face-to-face, and the main thing is a past history of skin cancer, so they have any of that, or on immunosuppression. It's really important that we understand, are there any risk factors, and also their performance status. We need a patient to be able to come up easily, undress, be able to identify the lesion and things like that. And then if in primary practice, when you're seeing the patient, if you think it might be appropriate for telederm, if you flag to the patient or even indicate on the form, then again, that would help us when we go to triage, because if there's already been a thought process that this patient might be okay for telederm, then we can triage into the telederm pathway. So that would also be very helpful. Next slide. And then just thinking about future plans. So what, at the moment, obviously, as I said, we're doing this post triage, but what we're hoping to do is provide a number of direct bookings, and these are direct bookings into an image acquisition slot. And so if you see a patient, you think, well, yep, they meet the criteria, they could do for telederm, rather than referring straight to a face-to-face, you're referring them straight to that image acquisition for telederm. There will have a really clear exclusion criteria provided, so you know exactly which patients it's suitable for. At the moment, also, these referrals that come in will have a secondary review. So this is a sort of an administration review to double check, just to make sure, yeah, this patient is suitable for direct booking into image acquisition. It's just a bit of a safety net for the moment. But obviously, we are exploring the opportunity to expand so that there will be more slots for direct booking, and also not only in secondary care, but also within the community as well. So this is an ongoing project, and obviously we will provide more information as soon as we know where we are with the project. And then also AI. So it's a really growing area, and there's a lot of media attention. And this is all around using AI to assess dermoscopic images. And then it's autonomous discharge of patients who are assessed as benign. So basically, it is the AI looking at the dermoscopic image. With all the AI, you plug it all in and it goes, yep, this is completely benign, and the patient is discharged without having to see anyone. So this has obviously been explored in our system. A recent NICE report has come out, and it has said that AI can be used for assessing and triaging skin lesions, and particularly on the urgent suspected skin cancer pathway. But obviously, if we deploy anything like that, we've got to make sure that we're maintaining good standards. And actually, the reason that we are exploring it at the moment without embedding it yet is that one of the things that's so important for this is to make sure that the image acquisition is really good quality, because actually AI only works when that image is really good quality. So that is what we're focusing on, making sure that each image is really top notch, so that then once we know that in each area, in each trust, we've got that, we can then, if everything lines up and everyone feels that they're happy to do it, we can then embed AI into that, and then AI will then obviously be looking at those dermoscopic images and be able to reassure the patients that do have completely benign lesions. So again, watch this space, and we'll tell you more as soon as we know what more things are coming up and when that might be. Okay, I think that is all from me. So very happy to answer any questions.
Thanks very much, Claire. That's excellent. So we've got good 15 minutes, I think, to pick Claire's brains and get lots and lots of advice. Anyone want to put their hand up? I've got a couple of questions myself while people are thinking. Claire, are you using sequential? Are there any research projects at the moment that sort of under your remit that are using sequential mole mapping to build the AI library? And how do people access recruiting to that?
So no, I say no. We do have a project. It hasn't been set up yet. But actually, yes, that's one of the things that recently got funding, as you say. So trying to build up a library, because actually one of the things with this AI, it's a private company. It's called Skin Analytics, and they keep all the images. So the patients are providing a huge image bank for them, and so we want to be able to do the same. And so there is a project. It's actually it's got funding it, and how we're setting up the image acquisition at the moment will hopefully help embed that within that project, because if we're taking the images on really good quality, those can also be used to build up a library. But it is absolutely essential. And the only thing that makes a library useful is if we can absolutely say, for those patients where they were referred for a biopsy, linking in the histological diagnosis back to the original picture, and then you really build up a really good AI library.
Yeah. And is that just single lesions, is it, or are you also looking at the sort of subgroup of people doing, people who have lots of moles for lots of different reasons and are having kind of mole mapping in a more of an Australian approach?
So all of these are single lesions, because they have to be dermoscopic. Now, the mole mapping you mentioned, there's no in the NHS, there's no mole mapping, but certainly privately, they do absolutely do that mole mapping. So you can have sequential sort of yearly, and then that AI will pinpoint a lesion, and then they'll go into that individual lesion dermoscopically to look at. But NHS wise, there's no mole mapping.
Really, across the whole sector? I thought that there were units that did it.
Well, so mole mapping is a term. It's a bit tricky because mole mapping historically was just taking pictures of your moles. So theoretically, anyone can have their moles photographed by a medical photographer. But with regards to sort of AI and things like that at the moment in NHS, it's literally, you know, the patient brings their moles and you look at the patient, you look at the pictures, and you're doing the sequential yourself, if that makes sense.
Yeah.
Whereas actually to have an AI comparing two images, that's definitely not available yet.
Right. Okay. Thank you. Anyone want to ask a question or pop it in the chat? The other thing I'd like to ask in the meantime is, I recently saw a patient with acute dermatomyositis actually in an NSS clinic. But I imagine one of the reasons why they came to us, in fact, was probably because people weren't sure about a same day or an urgent assessment, which is clearly what this patient needed. They were covered in rash torso, but anterior, posterior, and their limbs. And the story was, fitted well with dermatomyositis, which was ultimately confirmed. I wondered, you mentioned it, but I wondered if you could just describe it in a, point by point approach to how you would like people to access. That's how you advise they access the service. Best ringing in, or
so ringing in. So they carry basically. I'll say at UCLH, and I'm pretty sure it's a similar over the other trusts. So we have an on-call service during working hours. So it runs from 9 to 5, and they carry an on-call bleep. So that is always manned. And if you have a patient that you're really worried about and you need to see them on the day or the next day, you ring up the trust, say, "Can I speak to the on-call dermatologist?" Tell them about the problem, and then they'll say, "Yep, send the patient up," and we see them. You basically just send the patient up, and then we put them in as an acute review.
Okay, but it's via switch as opposed to direct access.
It's being carried up. They carry a bleep.
Yeah, right, rather than the phone. Okay, that's great. Thank
you.
So
maybe, I don't know, so certainly that's at UCLH. I'm pretty sure it's the same at the Royal Free. For the Whittington, I'm not sure whether they carry a bleep or whether it's via the secretaries, because they have a slightly different system.
Yeah. And I know that there are those of us among us who use Consultant Connect frequently for dermatology, and it's always worked well when I've personally used it. Has anyone had a problem using Consultant Connect with the dermatology? Okay. And there's Rebecca, you've put a question in the chat. Do you want to speak your question? Are you in a position where you can speak your question, or do you want me to read it out?
Yeah. Hi.
Hi. Thanks, Rebecca. Hi.
Yeah. Hi. Thanks so much. It's really informative and helpful to go through this. So my question is just to clarify about the urgent teledermatology suspected cancer pathway. So am I right in understanding that we use the same 2-week wait referral form and just state that this patient, if appropriate, is fine for a teledermatology assessment?
Yes, for the moment, we are trying to see how we can adjust that form to make it bit more user friendly. So right at this moment, yes, do that. Use the current form and just somewhere in your text say, this patient could be appropriate for telederm.
Okay, so from your perspective, when we trigger the ERS referral, everything else remains the same online.
Correct. For the moment, yeah.
And so at the moment, for lesions that I'm a bit worried about, so they may appear, I'm sort of thinking, I'm almost certain that this is just a benign nevus, but there might be some atypical features that I just want someone to cast their eyes on. I send everything to Consultant Connect. And I don't use telederm because the waiting time is significantly longer, but I understand now that the waiting times are shorter. So is there, in terms of audit tracing and I suppose accountability, is there a pathway that you would recommend that we use for those sorts of lesions?
I think both of them, actually, as you mentioned. Obviously, Consultant Connect, you are absolutely going to get a quicker review, without a doubt. Even though, as you say, routine telederm is definitely coming down, the wait list, it is still long. So I think those ones where you think, look, I'm almost 100%, but I still want someone to cast, you can use telederm. But equally, if Consultant Connect is working for you, you will get a quick turnaround. So I think both pathways, I suppose, depending on your level of suspicion.
Okay, all right, thank you.
Yeah.
That's helpful. Thank you.
Thank you. I might, I'm going to do something really naughty now. Nitika, are you online? I might have just lost her. Yeah, I think she's probably had to go to a meeting. Right, never mind. I can't be as naughty as I wanted to. I was, is that you, Nitika? No? Okay. I was going to ask her whether from Nitika's our cancer lead in Enfield, whether there were particular issues that had presented to her kind of in her cancer role. So if she comes back, we'll ask her that. But any other questions for anybody, or how are there bits of the pathways that you feel are tricky or that you'd like us to think about again? Perhaps, Claire, at least it's worth us asking that, or anything in particular that would help the experience that you're facing in primary care. Everyone's very quiet as well.
I have another question. I'm so sorry.
Thanks, Rebecca. Not at all. You're allowed to. Absolutely. Yeah, keep going.
So I find that I generate a lot of referrals for suspected actinic keratoses. I know what they need. They need some Effudix. I know how to, advise them to use it safely and to review it 4 weeks or whatever. Should I continue to always check with a dermatologist or not?
No, in fact, the guidelines I mentioned, there is an actinic keratosis guidelines on that, so that's actually really helpful. Because if you then follow that, you can sort of be reassured. Okay, yep, I'm doing the right things. But absolutely not. If you think, yep, this is an AK and you're treating it, that's fine. The things to look out for are the usual things. It's not responding well, it's getting lumpy. I'm not expecting that. So if everything is going as you expect, it's absolutely fine what you're doing.
Lovely, thank you.
Thank you. Can I ask you, going back to the guidelines around BCCs, Claire, and whether you should or shouldn't refer, and what you listed a set of situations where it would be more appropriate to refer perhaps close to an eye or close to the mouth. What about patients who have the sort of classic BCC on the pinna, where it's likely that waiting may not be life-threatening if they wait a bit, but will certainly mean they'll need a completely different degree of plastic surgery to manage that. So
I agree with you. Is that exactly right? So something where you think, if I let this grow, there's going to be a significant, maybe a significant cosmetic outcome. If it's on a pinner and they're actually going to lose a lot more of their ear, that's also relevant. One could think about is, for those patients, actually referring via a telederm, we could book those then straight in for surgery. So if it's very obvious a BCC, then they're not having to wait all that time for that first appointment. So where for BCCs where it really is very obvious, then a routine telederm can actually work quite well.
Okay. Yeah. Thank you. Okie doke. Any other questions from anybody? I wonder Rebecca, great. Off you go.
So sorry, it's all
No,
coming
please don't
flooding in now.
apologise. Ask them all, that's fine.
Thank you. So, for example, I saw a patient this morning with a rash on her buttocks and genitalia, and this has been going on now for 3 months. And we've tried all sorts of topical treatments, and it responds for a bit and then it recurs. I would really love to be able to take some photographs, but I didn't, obviously. And I'm sort of clutching at straws now about, composing a management plan for her. And obviously a routine appointment would be way too long. So I sort of formulated some sort of loose plan. But what would you advise in those sorts of situations would be appropriate?
So you can put those as, mark them as, obviously they'll need a face-to-face, as you say, because you can't take photographs of it. If there's any areas where you can take a photograph of a bit of it, if you see what I mean, but not the whole, obviously whole. If you can take a representative photograph and just explain, look, I haven't been able to, is there anything you can advise on telederm? And the other thing, that if they then come through telederm, if there's anything about that rash that is in any way worrying, then from that telederm, it'll be generated an appointment, and obviously then we can triage. The other thing you can do, if it's not telederm, put it through as an urgent.
Okay, great. So I could just take a snapshot of that area of skin without it being apparent that it's actually of the bottom.
Yes, and just explain exactly why you've done that.
Great, that's great. She was begging me to take photos. And
yeah,
that's great. Thank you.
No worries.
Thanks.
Yeah. And can I ask, Rebecca, the photos you'll be taking, would they be dermatoscopic photos?
Yeah, I'd be happy to do both.
Yeah.
Just to say, obviously for lesions you absolutely have to do a dermoscopic, but actually rashes, it's not really needed, and unless there's some feature, like, I don't know, lichen planus, where sometimes it can show nicely. Unless it's something like that, you don't worry about the dermoscopic picture.
Okay, lovely, thank you.
It would be helpful, just for our purposes, for all the people that are on the meeting today, can you tell me if you've got ready access to a scope, or do you have to spend 10 minutes wandering around the practice trying to find it if you wanted to take an image, or do you always get someone else to take an image? And if you would fancy putting that in the chat, that would be really helpful and interesting, actually. Or you could talk now if you like. Because there have been a couple of initiatives in NCL over the last sort of 2 years or so, 2.5 years, to try to increase the number of dermatoscopes in practice, but I still think there are an awful lot of clinicians who find it hard to get hold of them. So Roxanne saying she takes her own. Yeah, okay. Need to find it in the practice, Rebecca. Gosh, sounds if you need one on your desk, actually, the number of dermatology patients you'll see. Okay, yeah, absolutely. It's hard. It's really hard when you're trying to consult quickly and it's not on the desk. I think that's one of the problems. Okay, I'm conscious of the time, and I know that you have to go to your MDT. So it's been really great, Claire. Thank you very much for coming, and I'm sure we'll have you again when you've got to fit into your diary. But it's been really helpful. And for any of you who've got other questions that you weren't able to sort of ask in real time today, please feel free to put them in the chat. We'll keep it open for a couple of minutes now after the end of the webinar, and then we will deal with those and get back to you. If there are lots of questions, then we'll get back to people as a group so that everyone gets the benefit of the question and answer. But Claire, thank you very much.
No problem at all.
I'd like to say thank you to Andy, whose programme supports Claire and her team in all her work. And thank you also to the others of us from the Cancer Alliance who are here. Right, I think we're going to end now. I'm just going to ask before we absolutely close, Amelia, could you please put into this chat the same QR code that we were showing on the NCL webinar earlier this morning, which will allow you, if you use that code, it'll take you straight to a pre-populated email, where you are just agreeing, and you can say, I agree forever, or agree for the next 5 years, or whatever it is you want to do, where you're agreeing for us to drop any invitation on any webinar into your Microsoft Teams /Outlook diary, and then you choose to attend whether you want or whether you don't, but the link is actually there because you're agreeing on blank sort of across for all the talks, webinars. If you'd like to do that, there's that link for you. Amelia's put it in. Please do register, because we're having difficulty reaching out to people that we used to reach out to in different ways if you don't respond specifically about attending the webinars as a group of webinars. Okay, Thank you. Thanks very much, Claire. Much appreciated for coming. Thank you. And thanks to all of you for coming. Bye-bye.
Bye.
Bye.